must say I'm actually a little sad. This is my last lecture, and it's been a real pleasure. I've had a chance to meet some of you, and very, very lovely country, very lovely people, smart people, great food, good drink too. It's good. All right, so I'm going to go through kind of an algorithm, evidence-based, that we use in my center, in my hospital, to help us make some of these decisions of when we might repair a femoral neck fracture or replace. And yet, I must tell you that it's important to remember these are general decision-making recommendations, and a treatment plan should always be made for individual. You don't just always use an algorithm. Age cutoffs are not firm and universal, and you may have different thresholds and skills that would help influence your decision as well. So you need to make those decisions based on what you have in resources and your own surgical skills. But this is kind of in general how we go about making these decisions. So if I have a patient less than 50 years, we will always do an attempt at closed reduction. And if that reduction appears anatomic on the x-rays, and it has a low PALS angle, we do 3 screws, or FNS stands for femoral neck system. It's a new implant. I'll show you a picture of it in a minute. If it's a basilar neck or a high PALS angle, then we use a sliding hip screw with a derotation screw. If the x-ray does not show a perfect anatomic reduction after closed reduction, we will do an open reduction through an anterior approach, and the fixation options are the same. Those don't change, but they do. Fracture pattern is determined by that. So this is all based on good evidence. This is the device that I was talking about, just for you to give you a reference. You'll see a picture of it later. It's not important at this time. If the patient's between 50 and 60 years, it really depends on the health of the patient. So if the patient's healthy and active, no comorbidities, and has a simple fracture pattern that we can reduce well, we will treat like they're less than 50. If they're unhealthy, whatever that means, right? They have a lot of comorbidities or a highly comminuted fracture or have very poor bone quality, we will do a total hip replacement in these patients. This is a common problem here. So if they're between 60 and 90 years and have a valgus impacted fracture, and they have to have no retroversion on the lateral view, then we will fix them with screws or other device. If the valgus impaction is retroverted significantly, or it's not aligned and significantly translated, then we look at the health of the patient. If the patient is active and independent, we'll do total hip replacement. If they are not, we will consider hemiarthroplasty, and whether we do press fit or cemented depends on the quality of their cortex or their cortices. And so this is also supported in these references here. If the patient is very elderly, over 90 years of age, and they have acceptable cortices, then we will do a press fit unipolar hemiarthroplasty. If they do not, if it's the stovepipe femur, then we will do a cemented our hemiarthroplasty. So that's just the general algorithm, and now I want to take you through cases that demonstrate the application of this. So the first patient is a 41-year-old female. She's relatively young, healthy, and she fell because she didn't know how to wear her high heels. So she presents at 9 o'clock in the evening, and these are her x-rays here. You can see the AP and the lateral, and for some reason a CT scan was obtained. I think there was a issue of whether we're going to repair this and if there's a lot of comminution in the neck and whether that we're going to be able to get a good reduction. So this is here on the fracture table, and the question is, do we repair or replace this? And in my algorithm, because she's young and healthy and we have a very, very good reduction, anatomic appearing on both views with good x-rays, we will repair this injury. So assuming repair, a closed reduction was acceptable, so we don't need to do open reduction, and because she has a high PALS angle and close to a basilar neck fracture, we will choose a sliding hip screw device. So we follow this pathway here. It was anatomic, high PALS angle, sliding hip screw. And this was her fixation and her reduction, and she goes on to heal fine. This one's a little more interesting, a little more difficult. She's a younger patient, 27 years old, very healthy cyclist. She fell over on her bike because she couldn't get out of the clips. So she has this valgus impacted fracture. And you do see some retroversion there. She's younger, so we're going to give her a little bit of a break here. But she also got CT, and she has some inferior comminution. But she's also significantly impacted. So she's very stable. So we put her on the fracture table with preparation for open reduction if we need to. But these were her images here, and we had to make a decision. I don't think we're going to consider replacement in her, right? She's too young, healthy, and her reduction looks pretty good. The question is this acceptable? And in our thinking, this is acceptable because the other option is to try, if you take this out of the impacted valgus position, you now have created an unstable situation that will be challenging to fix and repair and possibly put her at risk of a problem. So this situation in our minds, we should just take this and fix it. So we did. And because it was subcapital, we used screws. So we follow this pathway here, and she gets 3 cannulated screws, as you can see here. And she did quite well for some period of time. She went on to heal us, but I just happened to hear from a colleague of mine that this patient, although was doing well, at 6 years she's starting to have hip pain, and for the obvious, whatever reasons, she's starting, looks like, getting some cystic changes and maybe some AVN at late. So, these are challenging fractures, even though I think we did the right thing. Here's a 17-year-old, and he was being a typical 17-year-old and didn't make his little flip that he was trying to do. So he has this femoral neck fracture, and this is the imaging here. So a very young patient, 16 years old, highly displaced femoral neck fracture. And his closed reduction on the fracture table looks like this. So I don't have the lateral here, but you don't really need to see a lateral because this is a non-anatomic appearing closed reduction. And in our hands, this is an open reduction now. So we don't accept this. This needs to be fixed perfectly because the reduction is the most important aspect of femoral neck fracture surgery. So we're going to repair this. Closed reduction was not acceptable. We do the open reduction, and it was high energy basilar neck, so he gets sliding hip screw with derotation screw. So we follow this pathway here. And just show you some quick things. We did this through Watson-Jones approach. I've now changed. I do 2 approaches now. I use an direct anterior approach for the reduction and a separate secondary incision for the sliding hip screw device. And you can see it was a difficult, challenging reduction by the number of K-wires. But we got as good of a reduction as we could get. Opening doesn't always mean it's going to be perfect either. Sometimes it can be challenging to get the reduction even if it's open, but it's certainly better than it was. So unfortunately, he went on to non-union, and he ended up with a valgus intertrochanteric osteotomy, but went on to do quite well. He did very, very well. The next patient is kind of one of these tweeners, right? These in-betweeners. 71, so she's on the younger scale of older. She lives independently. She drives her own car. She shops independently. She runs her own household. She just broke her hip because she swerved to miss a deer and she crashed her car. So the question is, in a 71-year-old healthy, active patient, do you attempt to repair or replace? Well, you look at her bone quality, and so this, in my mind, takes her out, and she's quite displaced. So this is a difficult repair, maybe not difficult repair, but the chances of her having a complication are very high. So we're going to not do repair on her. So the question is, if we replace this femoral neck, is it a hemiarthroplasty or a total hip? And in our hands, in an active elderly patient, we choose for total hip replacement. And I think there's good evidence to support this. If you have other experiences in your particular practice environment, in your community, maybe this is not the right option. But if you have these skills and the ability to do it, this actually can give you the best results for them. So this would be what her x-ray looked like. Here's a 75-year-old. She had a simple fall. She's medically healthy, but she had a valgus impacted stable fracture with no retroversion or translation on her lateral view. So this is an inherently fairly stable fracture. So we're going to probably choose to repair this in this patient. This is controversial because there is some literature to support even in these or the non-displaced fracture, a hemiarthroplasty would be indicated. But our experience with some newer, better implants, these are fixable and the patients can do fairly well. So this is that device I was telling you about. This is a new hip system that is coming out. We just had the fortunate ability to use it early. And this was my patient at 4 weeks. And compared to a patient with cannulated screws, she's not using an assisted device. She's got a little hitch in her, her giddy up, as you say in America. But she's walking at 4 weeks unassisted, and she's very, very happy, as she's going to show you right there. Smile. Oh, I missed the smile. Okay. Anyway, so at 8 weeks, she looks like this. There's not much collapse, and so she's doing fine. So we follow this pathway on the algorithm. She's well reduced on the lateral with a valgus impaction, and so she gets fixed. So our next patient is 76-year-old, low demand, ground level fall, significant medical history, right? She has this fracture that you see there. And because she's in this potential age range for hemi versus total, she's not a total candidate because she's low demand and she's sick. She's not an active patient. But she has good cortex, good cortices. So if we go to the replacement pathway, she's going to, in my hands, she gets a press fit hemiarthroplasty versus a cemented. So we follow the pathway here. And this is what her x-ray looks like. And then finally, you guessed it, no surprise here, I'll show you a different example of a 79-year-old man, again, medical problems, and this is his displaced femoral neck, and you can see the difference in his femoral cortices. These are very poor, these are very thin, stovepipe femur, high risk for fracture with press fit implant. So he gets cemented hemiarthroplasty. And this is what it looks like here. So in conclusion, these are just some general concepts, and you have to, in your own patient environment, your own hospitals, and your community, you have to make a treatment plan for your kind of patients. And you ought to remember that these are guidelines, and you have to treat individual patients. And so you have to take that in. And then you also have to know your own skill set and what's available to you for resources and cost, and again, in your practice environment. And then use the general guidelines to fine-tune based on your own individual circumstances. So I hope this was helpful in some way, just to show you kind of what we're thinking in my community in the United States. But again, thank you all very much for your hospitality and your warm welcome here. Thank you.